Before we start, who here does mitral valve and valve procedures? Okay, so about 40% of the room. Sounds good. So, mitral valve and valve procedures have probably happened off-label from the very beginning when transcatheter valves were available, both with the Edwards valves and the Melody valves. I'm going to start by showing you a case back when our program first started with one of our earlier mitral valve and valves, to show you how things have progressed, and then follow that up with a case that's been more recent. So I have no conflicts of interest for this presentation. So the first case is from 2013. It was an 80-year-old female with rheumatic heart disease. She had had 2 prior mitral valve replacements, tricuspid valve replacement, and atrial fibrillation. She was coming in with NYHA class 4 dyspnea with multiple hospitalizations over the past year. You can see her past medical history. Her cardiac surgeries included an MVR in 1976, followed by another MVR in 1996 with a 27-millimeter Carpentier-Edwards, and then a tricuspid valve replacement for severe rheumatic TR with a porcine bioprosthetic in 2004. So she had now on echo, she had a bunch of issues. Her tricuspid valve was working okay, but she had severe bioprosthetic mitral regurgitation and moderate bioprosthetic mitral stenosis with a mean gradient of 16. She also has severely dilated RV. She had elevated PA pressures and evidence of LA and RA thrombus, as these rheumatic patients are often very thrombogenic. On TEE, her mitral diameter within the bioprosthesis was 19.5 millimeters when she was being evaluated. Just of note, at this time of, her creatinine was high, but back then I didn't have a standard for doing mitral valves and valves. We were just usually using TEE. In TAVI, there was more growing literature at the time that CT was very, very good for annular sizing, but there was no such standard in the mitral valve world. Well, this lady is pretty much the only cases we were doing early on, which is sort of back in the Jurassic Park era of transcatheter valves, people who are relatively non-operative candidates. Her STS score is 32%. She was deemed to not be a candidate for traditional open surgery, and so she was recommended an off-label valve-in-valve percutaneous intervention for her mitral valve disease. At that time, and for most programs, almost all the transcatheter valve and valves are being done transapical. Now that has shifted in the last couple of years, but the transapical approach there was a lot of comfort with it, with TAVR as well. So just changing the angle, inserting the valve in the opposite direction, and then kind of putting it into the ring. So this is a case where once you get the apical axis, you get the valve in position, you rapid pace, and just like with any procedure, you blow up the valve and hopefully everything works. Now, this particular procedure was successful, but mostly I would say in retrospect by luck more than anything else. She was extubated, discharged from the hospital, but she had a prolonged hospitalization, and actually she ended up getting discharged from the hospital. She passed away 4 months later with continued congestive heart failure. So, these patients were incredibly sick at the time when we were initially doing these cases. So, who do you pick for mitral valve and valve? Well, I think the society guidelines still would say that, if a patient is a reoperative candidate, you really want to offer them reoperation for the majority of patients still, especially if they're low risk and intermediate risk. There's, you can consider it in prohibitive risk, of course, and in high risk, it can be a discussion. If you look at sort of the guidelines per se for mostly linked for aortic valve and valve, but you can kind of correlate it to the mitral valve and valve. Again, they say high or prohibitive risk in the recent 2017 ACC/AHA update that was published a month ago. For mitral valve repair, we already heard a talk on that. Same sort of candidates are kind of what the guideline addition happened this year. So how do you what are some of the criteria you want to think about when doing a valve-in-valve procedure in a mitral ring or a mitral valve? So first is you want to have appropriate valve sizing. There's a lot of different valves out there. In the general rule, you're looking at the internal diameter of the bioprosthetic valve that you're inserting into, and you want to look at that internal diameter because not all the valve numbers and the internal diameters are often varied and very different. You would think every 23 bioprosthetic valve is the same ID, but that's not the case. How can you find the internal diameter? Well, there's published tables. So having the operative report of what kind of valve there was is imperative. That's extremely important. You can look at these tables and get the internal diameter. Most of you who are doing these procedures know of the valve-in-valve app on the iPhone or Android. This is actually such a useful app. It gives you each valve in each different size. It tells you sort of what the valve should look like under fluoroscopy, and generally gives you a good correlation of which valve should be implanted. I will say, though, it is important not to completely rely only on the app, because there are times where you find where you actually measure things out on either echo or CT, and for whatever reason, what the app and what the reference guides would say, the internal diameters are actually different. The reference valve area is different, and we choose a different valve size dependingly. So the valves that are commercially available in the US off-label for mitral valve and valve are Edwards, XT, and S3. I will mention the Melody valve has been implanted and has been published in the mitral position. However, the smaller sizes in general make this valve less ideal for most adult patients that we're talking about. Okay, the second issue to think about is access choice. So I think transapical is how most mitral valves and valves started. Apex is definitely easier from the standpoint of getting, there's less drama involved leading up to the valve implantation procedure. From the standpoint of the apex is a direct shot into the left atrium. You can, if you need to do a double valve, someone has both AS and MR, you can do it just by shifting the angle and do them at the same time. You can, sometimes people feel you can avoid left atrial appendage clot by just going with a wire directly into the pulmonary vein. And if you need to deal with a paravalvular leak issue at the same time, well, you're there if it's in the mitral valve. And the other thing that I think is important is what the surgical feeling is. Our surgeon, Arash Salemi, our in-house outcomes with transapical have been really excellent. So I think doing the transapical cases for mitral valve and valve keeps surgical engagement, even though all TAVI is a heart team perspective, but it is nice. There are disadvantages, however. Those disadvantages are that obviously transapical is more invasive. There's movement towards femoral in general, especially based on some of the Partners 2 trial data that showed there was a mortality benefit in the femoral subgroup for TAVR, and so that correlation, patients feel that it might be better to do everything from the leg, and there's definitely some rationale for that. There's also some decreasing experience with transapical techniques, so I do know that a lot of surgeons tend to, some of them programs tend to shy away from transapical. They'll even do a direct aortic when they're dealing with TAVR. As far as transeptal, the advantage is that it's less invasive. There's less splinting afterwards in the recovery period. There's large vessel access is venous, so that's fantastic, and so less vascular complications from that standpoint, and it is probably applicable to most patients. Disadvantages are that it's challenging to control catheter movements, sometimes when you're going across the atrial septum, especially if there's poor radiopaque markers. You can imagine, even with modern day delivery sheaths and delivery catheters, there can be a little bit more motion and movement when you're blowing up the balloon. And you're left with an atrial communication, which isn't a big deal because, we're here. We like to close ASDs, but it's something to think about. Issue 3 is positioning of your transcatheter valve. We have to know thy valve exactly inside and out and what it's going to look like on fluoro. In general, you want to position the skirt to the sewing ring of the old valve. The ratio that we talk about for most valve in valves is going to be 20-80, 30-70 left atrium to LV, though with the rings probably more 50-50 because you don't want it to fall out. And so just from that standpoint. You also want to minimize catheter movement during deployment. This is not the cases, the rage is doing transcatheter valves with moderate sedation, not doing TEE, not pacing. These are not the cases you want to do that. You want to do all those things for these cases. You want to have as much of a controlled environment. You want to have general anesthesia. You want rapid pacing with cardiac standstill. And you want TEE guidance, especially when looking at the LVOT. So these are important principles to think about when positioning. One of the things, and I didn't show you, the patient case I showed you, one thing that was interesting about that case was her LVOT gradients, she had increase in LVOT gradients after the case, though you wouldn't necessarily expect that from the way the valve landed. And we didn't really think much of it because you sometimes see that in the post-op setting, but we're now starting to realize that LVOT obstruction is a big, big issue with transcatheter mitral valve in valve replacement. It can occur from either the covered portion of the stent valve, it can be from leaflet overhang, or the theoretical Venturi effect that we talk about in hypertrophic cardiomyopathy. You want to think about the actual angle of the aortic annulus and the mitral annulus that we were speaking about earlier. You want to think about maybe the lack of flaring, which is why maybe the next generation valves have the D shape. And you want to, the septal bulge in a patient can itself increase the risk of this happening. So these are things that you want to consider when implantation. Can this be predicted a priori? Well, there's a trial, the mitral valve trial that's going on right now. They're trying to predict a lot of these, in addition to actually implantation. They're doing CT scan imaging to get aortomitral annular angles. Now, the surgical literature says that aortomitral annular angles of less than 120 degrees are associated with SAM and LV outflow tract obstruction. Some of the transcatheter valve data is suggesting even lower angles, maybe because of the design of the valve and the fact that the old leaflet is still there, some on the order of 90 to 100 degrees. There's a case from Dr. Feldman. He presented, I believe, at either TCT or ACC, where he even did an alcohol septal ablation a priori to get rid of the potential obstruction that was theorized, and then did the transcatheter valve replacement, valve and mitral, which is interesting. So that's a TED thing to do. So, and the other thing to remember with this is, if the patient is non-operative, fine, fair enough, do what needs to be done if they're very sick. But when should you not do things? Well, one of those things are, that whole concept of if the mitral valve in there is so small that the next level mitral valve is going to create a gradient in and of itself that's significant, just like the the telescoping principle that we all think about in this field. Maybe that's not a time to do it, especially if they're high risk and you can convince a surgeon to think of an ulterior, another approach. If it's an MR issue, maybe that candidate is better served by a mitral clip. Or if they're not, if it's in vivo and not in a valve, hopefully in the future, Mark will be talking to us about the new mitral valves that are being studied. So those are the things that I would think about in going into these cases. I want to give a more recent case now. This is an 82-year-old female with a 31 millimeter EPIC porcine bioprosthetic valve that was placed in 2000, coming in with degenerative worsening MRMS. This patient has atrial fibrillation on Coumadin and is a Jehovah's Witness. Of note, when you look at the valve, you get mostly it's a mitral stenosis gradient. On TE it was 10. The mitral valve area on telemetry was 1.2. The MR was mild to moderate, but on while awake, the gradients were higher across the mitral valve. This patient was just sort of at that 8% high, almost the STS score group. It's important to note that our way we judge patients for valve procedures has really evolved over the past few years. We used to just look at the STS, give them a number and move on, and now we talk about STS. We give them other risk scores, frailty index, grip strength, and what's their BNP, and sort of what's in addition to the 1 to 2 surgeon evaluation. But in her particular case, because of her being a Jehovah's Witness and it would be a re-op, her STS was on the border. It was decided to do it through a transcatheter method. So through cardiac CT, you can get a sense of the annular area. Based on the annular area, you can also get an estimation of the aortomitral angle. Again, you'd like it to be more than 90 degrees, or at least more than, preferably the larger the better, to prevent LVOT obstruction. And this patient was suitable based on these parameters for a 29 Edwards. So this patient had a transeptal approach for the mitral valve implantation. You go across the septum, you create a septal window, and then you bring the transcatheter valve and deploy with rapid pacing. So in this particular case, we're going across in picture 1 of the transeptal, usually just using whatever you feel comfortable with. We heard all the transeptal techniques earlier. Switching over typically is an agilis sheath that gives you an easier way to just go through and kind of direct towards the left ventricle, get a wire in place. Various different wires can be used, degrees of stiffness. I think we generally tend to use more stiff wires still, but the literature suggests that people are moving away from the stiffer wires for these transeptal mitral valve and valve cases, moving to slightly more less stiff wires. You do an atrial balloon septostomy, and then you bring the Edwards valve across, you get it into position, and with rapid pacing, make sure you've got good visualization on your echo, lungs down, you inflate, and and that's sort of it. And then you're left with, this particular case was expanded a little bit more because there was a little bit of a paravalvular leak, and this was the final result. And then on this patient, finally, the mitral valve gradient was down to a mean gradient of 2. And there was only trace paravalvular leak. Though interestingly, you usually expect the paravalvular leak to get better, but her paravalvular leak got worse. It went to mild to moderate about 6 months later, which is an interesting kind of finding in this particular case. I'll show a few other cases in the last few minutes of time. The mitral valve and ring. I'll tell you, this was a 74-year-old female who had a 28 physio ring in 2003 with valve stenosis with a mean gradient of 12. You're kind of visualizing it here on TEE. In general, valve and rings is a less fulfilling procedure and I think a lot scarier procedure than valve and valve. The valve rings, they seem to be 1,000 rings. It's hard to keep track of them all. They're rigid. You know, what makes a ring better versus others? Well, they're characteristics of the ring. You need a circular ring that covers the whole area. Some are just semicircles. Those are no good. You want it to be circular to land your transcatheter valve. You'd like it to be rigid for anchoring, not very distensible, and you want it to be radiopaque. Also, the size needs to be adequate for the available valves that are out there. In this particular case, you know, this was a 26 millimeter S3 valve deployment. Same thing, rapid RV pacing, real-time TE, general anesthesia. In my opinion, not a time to be creative. So a down the barrel view of the valve and kind of what the result was at the end. So when it comes to valve and MAC, I spoke to one of my colleagues uptown, Dr. Nazif and Dr. Kudali, and they've done a couple valve and MACs for the mitral trial that's going on. There's less guidance in how to do it. There's not as much experience worldwide with it, but there's definitely cases. This was an 80-ish-year-old gentleman who had already had a bioprosthetic AVR 15 years ago, but had Hodgkin's lymphoma back in the 80s with lots of radiation. And when you look at this particular valve, it's not really moving. There is calcium there, certainly, in the annulus and on the leaflets, but this was, we thought, probably radiation-related changes to this valve in addition to MAC. The patient had high gradients and was quite symptomatic with congestive heart failure. So this patient had his cardiac CT to get a sense of the annular area. And unfortunately, the annular area, and this is the problem with MAC, you just don't know how much you're going to get distensibility or not. The annular area was 740 millimeters squared. Now, realizing that the S3 29 millimeter Edwards is technically the upper limits of normal for area, 683 millimeters squared. However, the diameter and the echo measurements and all sort of the other parameters seemed like it would work. So this was a go-ahead. And in this patient, same sort of thing. You got to get, same positioning exactly like before. But where you put the valve in relation to the left atrium to LV is anyone's guess. The biggest thing, what you're looking for is really not to cause that LVOT obstruction. So when you're putting the, and you should have done that pre-planning beforehand. And when you're getting the valve in place, often the echocardiographer will say, hey, this is looking like it's already too far into the LVOT, maybe come back a bit. That's sort of one of those things that hopefully as time comes and more experience with this happens, we'll get more data as to what are the parameters for considering MAC patients. Also, I think perhaps it won't be an issue when the next generation mitral valves are studied and approved for use in vivo, not valve in valve. So, that's interesting. So this was that case. This is the final valve. It was a good result. And so to conclude, again, transcatheter mitral valve and valve is definitely a viable option. Should be considered in either high-risk surgical patients or patients who are not surgical candidates. You definitely want careful pre-planning, dress for success. You want to image the inner diameter in addition to using reference tables or apps. Always consider the risk of LVOT obstruction. Procedural techniques and the approach make the difference between success and failure. That's true in everything, though I'd say in pulmonary valves and mitral valve and valves, it's even more so than in the majority of transcatheter valves. It's probably they're both slightly technically harder procedures. And the experience with mitral valve and ring, I think you don't always get great results, but these are cases that you're going to get because a lot of patients will go to surgery still as their first repair. And the experience of mitral MAC will have to remain to be seen. There's just a few out there. All right.
I think in the interest of time, Mark, if you can come up and get ready for your next talk. Question for Simran. John.
Yeah, Simran, since, obviously a partner site and
Yeah.
so big transapical, so now that the dust is settled and there's a lot easier ways to do this, I know you wanted to engage your surgeon, but it's way bigger. It's a way bigger.
Yeah.
So is there, can you tell me the reasons you wouldn't do it transeptal? Now,
Yeah.
You have only experience mostly with partners, so
Right.
with XT and everything, but you know actually the melody valve is very simple to deliver because it's already self-contained. It goes right over.
Sure.
It's very easy. It's longer, so you don't have the worry of things. You can make it shorter by folding. So I'm just kind of interested though, how many now do you do transapical versus transeptal?
That's a great question. So I would say that at downtown campus at Cornell, we still do about 75% transapical. On uptown campus, it's the reverse. They're doing about 75% transeptal. And that's, again, a lot of that is discussion between what the different teams feel comfortable with as far as what their comfort level is. And also, you know, I do think it has a lot to do with, you know, who did a lot of transapicals and who feels, from the surgical standpoint, our surgeons feel very, very comfortable with the transapical procedure. Again, you're right, it is more morbidity. The procedures with transeptal are a lot longer. They're, no question, they take with the Edwards valve, yeah. We have not done them with the Melody valve. I've seen publications. You've done them? Yeah. I think the only concerns with the Melody valve are really just the sizes, for one, because sometimes you want as big of a size as you can in the mitral position. Maybe the length, you mentioned you can fold it, but that whole LVOT obstruction, that might be something to consider as well.
Do you think that there's any role for circulatory support with an Impella device in high-risk cases?
So probably yes is the answer. That it could be reasonable to use. We have not done that at this stage. We have done an Impella device in a patient who was crashing on a mitral procedure because, you know, they were worried about the size of the arteries for bypass, for kind of doing ECMO. But Impella was just sized, and even that was sort of a questionable. There were 3 millimeter arteries from below. But no, we don't routinely do that, even on the very sick patients. But it's a good thought.
Any experience with tricuspid valve ring?
Yeah, so we have not in our center. We've done 2 mitral clips on tricuspid valve for TR, but we have not done a valve-in-valve in the TR position. At Uptown campus, there have been multiple procedures done. I'd say about 15 total is the experience in valve-in-valve, and it's relatively this. You meant valve-in-ring. So I do not know of any valve-in-ring. I know we've done valve-in-valves, but I don't know of any valve-in-rings in the tricuspid position. Have you guys done any in Toronto here?
We've done a lot of tricuspid valve and valve.
Yeah.
But not valve and
Not valve-in-rings, yeah.
So in neck patients,
Yeah.
have you seen any report of circumflex coronary artery getting obstructed by calcium?
So that's one of the concerns out there when you're blowing up the balloon, definitely. I have heard of people having arrests afterwards, but the problem is they've also usually been, the biggest problem has been pericardial effusions from actually rupturing the annulus. You think it's calcified and it'll do fine, but that's the complication that we have heard of. We have not seen that, but that's what we've heard of up to this point. But whether the circumflex was also compressed at that point, it's definitely a concern. I know it's an interesting thought, because in the TAVI world, when we do these valves where we think that there's leaflets or overhang is borderline or the coronaries are borderline low, we'll often, and I was thinking about that complication case presented, we'll often wire a priori and have a stent in place, even pull the guides up, deploy the valve, and if you don't need the stent, take it out or deploy the stent if you need to. Often, a couple times in the left main it saved us, and a couple times in the right. But I will say that I'm not sure, this would be a different issue, because this would be going down to the mid-circumflex with the compression. I guess the same principle could apply, but I have not seen that done yet, like kind of protecting the circ while doing it. It would be easier, certainly, because your aorta's free to go.
Thanks a lot,
Okay,
Simran.
thanks a lot.